You do grow as a individual and as a doctor, and your focus changes from being the important doctor in the room to being actually the person who's helping people and minimizing risk. And you embrace technology. There is no typical patient. I think the beauty of what we do is we provide a very personalized service. It really is quite phenomenal, being able to do surgery without having to lift a scalpel. Technology really did change the scene of neurosurgery over the years, and nowadays we don't clip aneurysms, we tend to coil them.
Yes, yeah.
And that means that people don't have to have big operations on their head. You can have a minimally invasive approach to the groin. And of course, you are much better off for having that sort of intervention.
Yeah.
One would only perform surgery for conditions when you've really exhausted all other options, and when the condition is severe enough to really affect somebody's quality of life.
Well, thank you very much, Ludvic, for joining us this afternoon just to talk a little bit about the services here in Queen Square.
Pleasure.
But first of all, I have to read your titles because you are Professor Ludvic Zrinzo, Consultant Functional Neurosurgeon, Head of Department, Head and Clinical Lead of the Unit of Functional Neurosurgery, Department of Clinical and Motor Neurosciences, UCL Queen Square. What a mouthful.
Well, with a surname like Zrinzo, would you expect anything easy?
Tell me how you got to this position.
Gosh, that's a bit of a story. So when I was a teenager, I was really into my maths and my physics.
Mm-hmm.
And I really did not want to be a neurosurgeon. And you'd think, why would you not want to be a neurosurgeon? And that's because my father was one.
Mm-hmm.
And he was Malta's first neurosurgeon, and at that time only neurosurgeon.
Gosh.
So he was on call every hour that God gives. So, of course, I hated his job. It was the one thing that kept him away from us.
Yes, of course. What sort of era are you talking? 1960s?
Oh, we're talking the 80s.
Yeah.
So I grew up in the UK until I was 10. I went back there in 82 because I couldn't stay here on my own. And my father and my mother, who's a radiologist, set up a neurosurgical service in Malta.
I didn't know she was a radiologist.
Yes. Yeah, you can see that, putting radiology and neurosurgery together brought me here, but more of that later. In any case, when I was 14, 15, you may be old enough to remember there was a hijack.
I do, yeah.
PLO terrorists forced an Egyptair plane onto the ground. My father disappeared, went to the hospital because the terrorists were shooting passengers in the head every hour and throwing their bodies out of the plane. And then there was an almighty disaster when troopers stormed the plane, and there were a huge number of casualties after that.
Yeah.
And the bottom line is my father came back 3 days later with a stubble, having operated on 5 of these people and saved the lives of 3 of them.
Gosh, yeah.
And I remember being, first of all, absolutely shocked by this terrible, inhumane thing that was happening around the corner from where I lived.
Yeah.
This was before 24-hour news and internet, and I thought you could never shoot somebody in the head in cold blood. That was something you did in the Middle Ages, not something you did in the 20th century. And then I remember being quite surprised that this person who'd saved people's lives lived under the same roof as me, and I had a whole new admiration for the man.
I bet you did. Yeah.
And I realized why that he was, putting his time to good use when he wasn't with us.
Mm-hmm.
And much to his disgrace and chagrin, I ended up changing and doing medicine instead. And he was very much against that because he really wanted me to do engineering.
How was that? Why would he want you to do engineering instead of medicine?
I don't know. I think he had a latent mathematician inside of himself, and we all live vicariously, or sometimes want to live vicariously through our kids, I guess. Yeah. A mistake I hope I'm not committing. But yeah, and in some respects, I've ended up doing quite a lot of research into physics as well, because MRI is something that I'm really fascinated in and is really important in the subspecialty I do. So, it was a wake up call at a formative part of my life. Mm-hmm. But I never dreamt that I'd be doing functional neurosurgery.
No.
And when I came to the UK, to specialize in neurosurgery, I dreamt of being a vascular neurosurgeon, clipping aneurysms and doing these big, rather dangerous operations. Appealed to me as a young doctor. But then again, technology really did change the scene of neurosurgery over the years. And nowadays we don't clip aneurysms, we tend to coil them.
Yes, yeah.
And that means that people don't have to have big operations on their head. You can have a minimally invasive approach through the groin. And of course, you are much better off for having that sort of intervention.
Yeah.
And you do grow as a individual and as a doctor, and your focus changes from being the important doctor in the room to being actually the person who's helping people and minimizing risk. And you embrace technology.
Yeah, I think that you also work very collaborative with team, don't you? It's very much a team approach. It's what I've seen of you working with your colleagues.
Totally. I think neurosurgery has evolved over the decades and years, as has medicine. And I think lots of areas within medicine are embracing this team approach. I think it's good for patients because they get the expertise across a wide range of people. I think it's good for the people working in those teams because you feel more supported. I think it gives you time that you're not always patient-facing, which means you can dedicate some time to research.
Yes.
When other people are carrying the can, so to speak.
Yeah, I'd like to get onto that with you as well.
And I think that team approach really is something that keeps it fresh. It's a job that no 2 weeks look the same, let alone 2 days.
So, in terms of what you are clinically doing, can you just tell us a little bit about your workload, what patients you're dealing with?
Right. Okay. So, I specialize now in something called functional neurosurgery. And the word functional means that it's putting the emphasis on trying to improve the function of the patient in front of you. So in opposition to other branches of neurosurgery, for example, oncology, where you have a tumor that's distorting the brain, that's pressing on the brain, that's threatening the life of that person. Very often in functional neurosurgery, you're operating or helping patients whose brains look physically normal. Structurally, they look normal, but they're not working normally. The function is affected. And the commonest disease we treat is Parkinson's disease. So if you were to take somebody with Parkinson's disease and scan them, there are subtle changes and differences between their scan and somebody who doesn't have Parkinson's disease, but overall it looks very much the same as somebody who hasn't been affected. But the circuits within that brain are not functioning properly, and they're driving symptoms like tremor, like stiffness, like slowness. And because we understand how the brain processes information, we can intervene. And we have lots of different tools to intervene to help patients with these functional disorders.
Fantastic.
So Parkinson's disease is one of them, tremor is another, dystonia is another, but we can also talk about mental health problems such as depression, severe refractory OCD, or Tourette's, which is a disease that bridges, if you like, neurology and psychiatry, because you have both mental issues and movement issues in patients with Tourette's.
I'd have to sort of fact check myself, but there was an extraordinary thing I was listening to the other day, and it was about the increase in mental health, and particularly young people. And that is just a sort of almost a time bomb for us as a society, isn't it? So do you think that some of the things that you're doing, the techniques that you're doing, will be able to help those in the future?
Well, I think you touched on a really important point, which is mental health is extremely important to each individual. And I think at some point, when enough pressure is placed on any individual, they will crack and they will exhibit symptoms of mental health problems. I think one of the explosions we have in mental health is society driven, in the sense that if people don't have enough money to look after themselves, look after their loved ones, then of course they may develop mental health problems. The answer to that is not medication and brain surgery. It's making a more caring society. I'm fascinated by the importance of sleep, for example. Children need more sleep than adults. And yet we force them to get up early in the morning to go to school while the parents are at work because they have to work. Both parents have to work. And then we're surprised when they exhibit symptoms of being, a little bit lack of attention, a little bit anxious, a little bit rebellious, all of which are symptoms of ADHD. And I'm not suggesting that ADHD isn't an important and real diagnosis, but perhaps we should be thinking about allowing children to have more sleep before we put them on drugs that ramp them up and make them more hyperactive. So I think there is a tension here between organic problems or disease states that are driving mental illnesses, and societal pressures that are driving mental
and expectations.
Illnesses. I think we need to approach that from both sides.
Yeah, important point. Can I just ask you a little bit about a typical patient that you're doing in surgery at the National Hospital here? So, who are they? Who are they? What's the disease, and how are you fixing them?
Well, the first thing to say is that there is no typical patient. So I think the beauty of what we do is we provide a very personalised service. And really what you need to do in functional neurosurgery is try to get to know the person and get to know how the disease is affecting that person and understand what is in our power to help and what is outside our power to help. So take the example of Parkinson's disease, for example. We have a really great group. You were talking about multidisciplinary care. Yeah. Although I'm a neurosurgeon, I work very closely with neurologists, doctors who help people with medications rather than with surgery. And they're a great group of neurologists who really know how to treat and manage people with Parkinson's disease with medication and with lifestyle adjustments. But when they reach the point that disease is no longer adequately controlled, they ask us whether surgery can help. And
can I just ask one sort of slight question? Do the drugs stop working at some stage, or will it inevitably stop working at some stage? Or
so what many of the drugs that we give for Parkinson's are doing is they're replacing some of the neurotransmitters that are lacking because of the degenerative disease. And one of the problems is that sometimes the brain can't handle that continuous dose of medication, and you get what are called on and off phenomena, which means that sometimes the brain has enough medication and people feel fine, but then the dose wears off, and then they grind to a halt and find it difficult to continue their journey. For example, if they're out of the house, it leads many people to start closing their environment and not leaving the house because they're worried that they'll leave the house and then not be able to make it back. And you really don't want to let people reach that stage before you treat them in some other way. So in general, people who start exhibiting symptoms of Parkinson's disease do really well with medication. And some people, that's enough for the rest of their life.
Sure.
But in some people, around 5 years to 8 years after starting medication, they start to struggle.
Right.
And the medications don't do a good enough job.
Yep.
And that's where that multidisciplinary approach comes in.
Yep.
We need the neurologist to tell us, actually, we really have tried with medication and it's not working.
Yeah.
Because you don't want to operate on someone who can do well with the tablets.
Other options, still on the table. Yep.
So then we have that multidisciplinary approach to try and assess how the disease is affecting that person, what the major problems that person is facing. And then we have an armamentarium of tools. There are different surgical tools. And I started off with functional neurosurgery where all the rage was deep brain stimulation. And it's a really useful and powerful tool. This involves putting tiny little electrodes specifically and very precisely, of course, very safely in areas of the brain that are, if you like, misbehaving and driving some of the symptoms that we see in Parkinson's disease.
Right.
And we attach those electrodes with wires underneath the skin to a little pacemaker, a battery that sits underneath the skin on the chest wall.
Right, okay.
So there's a pacemaker for the brain rather than the pacemaker for the heart. And using this device, we can interfere or modulate how the brain processes information. And we can help things like tremor, like slowness, problems with walking. We can't help all the symptoms of Parkinson's disease, and therefore we need to understand which symptoms are bothering the person, whether it's likely that we can help them or not.
So that's their quality of life, isn't it? What is really affecting them?
It's all about quality of life. And that's why I say there's no typical patient. We have to tailor the tools that we've got for them. And deep brain stimulation was introduced in the 1990s. I'm very fortunate.
It sounds terrifying, I have to say. Opening up the brain and putting probes in, but
it does sound scary, but in actual fact, it's one of the simplest procedures that we do.
Oh gosh, okay.
We've got it down to a fine art.
Yes. Because you are the biggest unit in.
Well,
UK
if I
Europe?
take that back, I'm very fortunate to work with a neurologist called Professor Limousin, Patricia Limousin, and she was a pioneer in deep brain stimulation when it was being developed in a tiny little town in the south of France called Grenoble.
Yes.
And she moved to London, and I was still a trainee when I met her, and she was very inspiring.
Yeah.
And we've revolutionized or changed how this surgery is done. So back in the 90s, surgery used to take the best part of all day, sometimes 20 hours to do this operation, and sometimes staged over 3 days in a week. Again, with a lot of support from Professor Limousin and Professor Harris, who was my mentor on functional neurosurgery, we optimized the workflow and leveraged the power of this wonderful other tool called MRI.
Yep.
So that we could operate on patients while they're asleep, because part of the problem is that we had to operate on patients awake before. Under a local anesthetic to see that we were in the right spot within the brain.
Yes, of course.
So we had to assess them clinically.
Yeah.
Withdraw their medications, which was very tough for patients.
Yeah.
And as a result of all the research we did on imaging, we could see the targets that we wanted to hit.
Yeah.
And not only see them, but check that we'd hit them on using imaging. And nowadays we can do 2, sometimes even 3 procedures in a day, in a normal day.
That's extraordinary,
so
isn't it?
it means we can, people are much more comfortable having the surgery. The risks are much less.
Yes.
We can reach more people. We can provide the therapy to more people. And as you said, last year we did over 40% of all the procedures, DBS procedures in the country.
That's fantastic.
Again, working with a wonderful team of 4 neurosurgeons, 2 neurologists.
That has to be one of the biggest teams in the UK, isn't it?
It is.
Yeah.
Yes. So we were talking about the different tools that we have. Mm-hmm. So we can use this tool, deep brain stimulation, to target different parts of the brain, help people with Parkinson's, people with tremor, people with dystonia, and also people with mental health conditions. So we've done trials of deep brain stimulation in Tourette, trials of deep brain stimulation, obsessive compulsive disorder, OCD.
And are you able to say how successful those trials have been? Are they
Sure. So our trial of DBS for OCD was very successful. It was a very small trial.
Yes.
Only 6 patients, but all 6 patients saw benefits.
Fantastic.
Lasting benefits in 4 of those 6 patients.
Great.
And in some people, it particularly transformed their lives, going from living in a mental health institution to volunteering for work, being in a relationship, traveling the world.
Oh, fantastic.
And it's very rewarding.
Must make you feel so wonderful as a team. It must be so...
It can be very rewarding.
Yes,
absolutely.
Exactly. I would imagine because those patients would have been the extreme behaviour, so OCD.
For sure.
Yeah.
For sure. We're talking, again, one would only perform surgery for conditions when you've really exhausted all other options. Yeah. And when the condition is severe enough to really affect somebody's quality of life. So we're not talking garden variety OCD here.
Yes, yeah.
Our first trial of deep brain stimulation for Tourette was so encouraging that we actually have just finished recruiting and collecting the data for a second trial of Tourette, of DBS for Tourette. Yeah. I'm actually quite excited because there's been a project that's been going on for the past 4 years, and we'll unveil the blinded randomized data in the coming weeks. So I'm really excited to see what the result will be.
Absolutely.
And we're very hopeful that if they're positive, as we hope that they will be, that will convince NICE, which is the body in the UK that looks at the evidence for certain therapies,
really? Yeah.
Sure, to say that we should be offering this on the NHS for patients who have been severely affected.
An extraordinary debilitating disease, isn't it? I remember getting a tube not so long ago, actually, and you must have had a clinic, because there was a young guy who was about 30-odd, and he was standing up and he was displaying behaviour of Tourette's, and you could just see him, head down, and everyone looking at him, turning around, and I thought, how dreadfully sad for that young guy. It was affecting every part of his life, because he was constantly shouting, different words. And I thought, there's something that can be done for him that would be wonderful.
Once again,
it's encouraging, isn't it?
Yes, it's also how society interacts with people who are sufferers.
Yes.
And again, having some compassion from society can make their lives a lot better. Yeah. But at some point, you really do want to treat these really serious and severe symptoms that, as you say, affect every facet of their lives.
Yeah.
So we talked a bit about deep brain stimulation.
Yeah. What else is in the toolbox?
So one of the other ways that we can disrupt the function of the brain, or the abnormal function of the brain, is something called ablation, where we're actually making a tiny little burn very precisely within the circuit that's malfunctioning, essentially.
And are you using the targeting techniques of deep brain stimulation to do exactly the same thing?
Absolutely. Yeah. So early in my career, really, we honed the methodology of visualizing these anatomical targets, understanding the circuitry of the brain, and putting electrodes in that part of the brain with the safety of being able to turn those electrodes off or take them out if you didn't like the effects. But with the vast knowledge of medical science that's out there and that's been published, plus our own personal experience, we started to realize that sometimes you could make a tiny little burn in the brain instead of putting an electrode permanently down. And there are some advantages to that in particular patients.
Yep.
So, for example, in patients with tremor, and all they have is tremor, making a tiny little burn in the part of the brain that's driving the tremor can abolish that tremor without the patient having to live with wires inside them, without them having to have pacemakers, without them having to come for follow-up visits where you adjust the electrical dose that you're giving to the brain. It's much cheaper therapy, so it benefits the patient from the individual point of view, but society as well from the financial point of view.
So so just so I get this right, the RF ablation is essentially for tremor, but you can use it for Parkinson's dominant tremor. Is that correct?
Correct. So you can use
patients who have no other sort of symptoms, inverted commas, of Parkinson's, just the tremor. You could use that as a tool.
Absolutely. So radiofrequency, you mentioned radiofrequency. This is the, if you like, old-fashioned technique of how we make a little burn. So essentially you put an electrode in the brain, so you still have to make a little hole in the skull and very precisely place that probe in the right spot. And then you heat the tip of the probe up to make a tiny little burn around the probes. And that can disconnect the abnormal circuits. We like doing this with patients awake, which again sounds very scary.
Exactly.
But all of our patients tell us actually they'd rather come to us again than go to the dentist, and that's mainly because
that's saying something, isn't it?
Well, nobody likes going to the dentist.
But something really stupid. How big is the probe? Is it like a pencil? How thick is it?
You have different sizes, and it depends. So we don't just use this for tremor. We can use it for obsessive compulsive disorder, for OCD, and for depression as well.
And is it a different part of the brain that you're targeting?
Correct. It's a different part of the brain, and the lesions need to be a different size, which is why we have a variation of sizes of probes. The ones we use for tremor are just 1.5 millimeters in diameter.
Oh,
so
gosh.
they're quite small.
Yeah.
And the lesions we make are maybe 2 or 3 millimeters in diameter.
For some reason, I thought it was...
No, these are absolutely tiny, absolutely tiny. I tell patients the lesion we make is less than a quarter of the size of my fingernail.
Gosh, okay.
Right.
Yeah. But that's precision, isn't it? That's targeting precision.
But that's why we like them to be awake, because we want to see that we're in the right spot without causing problems before we make a permanent ablation.
Sure. Yeah.
So we've moved not from just offering deep brain stimulation to offering radiofrequency ablation, and we tailor the selection of that tool depending on the patient.
And that's decided at MDT.
Everyone
makes a decision about what is best for this patient.
We talk together. Yeah. We also talk with the patient. The patient is part of that decision process.
Yeah.
Of course, they need guidance.
Yes, of course.
But our role there is to inform patients, not to tell them what to do.
Yeah.
But of course, they're there for guidance too. So very often we can guide them towards one therapy or the other if we think that's in their favor.
Yeah.
But honestly, we're just very open about what the advantages and disadvantages are of each therapy. And sometimes they go for something that we're surprised that they went for.
Yes.
And then we realize they have personal reasons why they, for example, can't travel for deep brain stimulation adjustments.
Yes, of course.
Or we use different types of deep brain stimulation software that allows us to program remotely, for example. So it's all these tweaks. As I say, there is no typical patient. Every patient is an individual. And of course, the latest kid on the block, if you like, the very exciting technology is focused ultrasound. And just like multidisciplinary teams where you get the expertise of different people all contributing to a better quality of care, we have the same thing with tools. If you get different areas of science that come together to make a really unique tool that we can use as a team. So the beauty of focused ultrasound is that we're drawing on decades of experience, both in terms of MR technology. So we're using MRI to visualize the brain in unprecedented detail. Yeah. And we can see the targets that we're trying to hit. And then the real nugget is the focused ultrasound bit. So what has been developed fairly recently is that you can use ultrasound waves. These are exactly the same ultrasound waves that we use to see a baby in their mummy's tummy, but of higher power. But each beam, we have hundreds of beams, each one with a very low amount of energy. But if you overlap them or focus them on one spot, they can deposit their energy in the tissues, and they raise the tissue energy temperature, and that causes a little burn. So just like using the radiofrequency of a probe to disconnect the circuit by making a tiny little burn, we can focus these ultrasound energy waves on that part of the brain to make that little burn. And it really is quite phenomenal, being able to do surgery without having to lift a scalpel, right?
Yes.
It's a wonderful idea.
It must have taken you your head to get around to that concept.
It's the closest thing to magic, It really is quite wonderful. So marrying this MR technology to the ultrasound technology, one of the biggest steps, if you like, was in the early 2000s, because the skull stands between us and the target. And the skull absorbs a lot of energy, but also refracts energy. So just like if you put a spoon in water, the spoon appears bent because the light rays are bent by the water. Sound waves can be bent by the skull. But you can calculate the angle of that and change the angle of your ultrasound energy. The physics behind it is just beautiful. And in the early 2000s, they figured out how we can refocus all these energy beams so that all the energy is deposited in one spot. So you can make a really quite precise lesion. So putting these two together gives us a third tool. So we've had deep brain stimulation, we've had the radiofrequency ablation, and now we have MR-guided focused ultrasound, or focused ultrasound for short. We sometimes call it FUS because it's a bit of a mouthful. So currently the biggest experience has been with tremor. And this has been approved for tremor in the UK.
Is that by NICE?
That's by NICE,
yes.
And so therefore it's commissioned by the NHS. And what has been shown in randomized controlled trials, and that's the beauty of science, right? In medicine, people have gone into this focused ultrasound machine and been randomized to having the machine switched on or to having a sham ablation procedure. And the patient and the people assessing that patient were not aware as to which group they were in. And then when you compare the two groups, there is a significant improvement in those who had the ablation switched on versus those who didn't.
And my sort of understanding is that, you perform this technique, and these are patients who literally cannot hold a cup in their hand and then come off the table and they have a cup of tea.
So the results can be quite remarkable. And as you say, it is these individual patients who have such terrible tremor where you get the most gratification, if you like. You will remember one of our ladies who had severe tremor on both sides of the body, who had been running around to try and get therapy for 6 years. Whose husband had to do everything for her. She had to feed her, had to help her drink. She couldn't even hold a cup in both hands, let alone in one hand. Could hardly use a cup with a straw. And then seeing her come out of that focused ultrasound machine and being able to take a drink on her own. But it's the things that you don't think of that are the most important. I mean, the other thing she said is, I can now do my mascara. I would never have thought about wanting to do your mascara, but that's what's important for her.
Absolutely.
And it's these little nuggets and gems that I find it's just it is science, but it's such a humane science. And it's not just the patients who have severe tremor. You can have minimal tremor, or what we consider minimal tremor, but patients are so ashamed or embarrassed by this that they recluse themselves from society and they withdraw, and then they flower when the tremor goes away.
Life, isn't it, really?
So it's not the severity of the symptom, it's the severity of how that person's life is affected by the symptom. So coming back to that function aspect.
Absolutely. And you talked a little bit earlier about research. So out of all of the techniques with MR guided focused ultrasound, where do you hope that's going to go? Where's it going to take you?
Well, as I say, it's a really exciting tool.
Yep.
There's already been research for tremor, and that means that is now approved.
Yep.
There's a lot of ongoing research. At the moment, it's only approved in the UK for unilateral treatment in patients who are not suitable for deep brain stimulation.
Right.
And I personally take issue with that in the sense that I think we've forgotten this thing that was bandied around 10 to 15 years ago about patient choice.
Yeah.
I think patient choice is exceedingly important.
Yes.
You may think that deep brain stimulation is better for this patient, but if the patient feels that they don't want electrodes inside them, and they can get, 60% of the benefit of DBS, but they can get it without having hardware inside them. If that's what they want, why aren't they allowed to do that?
Yes.
So I think we do have to listen to our patients, and I think the bodies who give guidance have to listen to patients.
Yes.
But coming back to the fact that at the moment this is only approved in the UK for treating unilateral essential tremor. But there are studies coming from overseas showing that actually it can be effective for bilateral surgery. I have concerns about that because the risks of surgery do go up when you're doing bilateral intervention. But in well-selected patients, those risks are actually very, very small.
So that patient you were talking about earlier who had quite dramatic tremor in both hands.
Absolutely.
Fantastic that she's got one hand that's functional.
She actually went on to have the other side done, and the second side, dare I say it, is even better than the first.
Are you just getting better at it?
Well, I think there's lots of exciting areas of research to expand the therapy for patients where we have a really good feeling that they are doing well.
Yes.
But we need the evidence to show that it's not just our gut feeling, but we have the scientific evidence to show that that's the case. The same is true for other causes of tremor. So at the moment, we treat mainly essential tremor with focused ultrasound. The results of focused ultrasound for Parkinson's tremor are good, but don't seem to be as good as for essential tremor. And therefore, I think there's a lot of research to be done to see how we can improve that therapy and to understand how and which tools are best used in which patient populations. There's a lot of exciting work coming out of Switzerland and other countries looking at lesions of the other areas of the thalamus for dystonia.
Right.
And also for chronic pain conditions.
Yes.
These are, especially pain, is a really difficult area of research because pain is hugely individual, the causes of pain. So trying to get a group of patients together with the same sort of pain to try and understand how they respond is very challenging.
It would be fantastic, though, because, again, absolutely disabling if you've got that terrible chronic pain.
So one of the people within our service has a special interest in helping patients with chronic pain, and we've made inroads. So Mr. Akram is very interested in that.
I'm going to have him on our next podcast.
Fantastic. I won't steal his thunder. I'm sure he's got lots to talk about, both in terms of deep brain stimulation and in terms of focused ultrasound and its potential.
And these sort of, areas of research that you want to do, where's the money coming from to fund it?
Good question. Before I come to the funding, I mean, the other exciting area of research is mental health disorders. So there's already research coming out of Korea and Canada showing that we can use focused ultrasound in a very similar way that we use already in the UK to radiofrequency ablation to help patients with severe refractory OCD and depression. And these are vastly under-resourced and understudied severe illnesses. I think it's really exciting that we've got more tools that we can investigate.
Absolutely.
The money for research is varied. We're living through times where, unfortunately, the new administration in the US is cutting funding for research in the US.
Dramatically so,
which is very sad for the world, but it's also an opportunity for the rest of the world.
I was going to say, would that be good?
Drive.
Because if they're not going to spend it in America, maybe others are going to spend it somewhere else in the world. Is that an opportunity for us?
Well, I think that is an opportunity, sadly, because I think we shouldn't be making opportunities of other people's bad luck. But, for example, the application of scientists going to work in Germany has doubled over the last few months from the States. So I think there's going to be a little bit of a brain drain in the opposite direction to to, you want to live in an environment where research is encouraged and enabled.
And collaborative, isn't it?
Absolutely.
Worldwide. Because
Absolutely.
I know from, we've talked before, but some of your research studies are very much international, aren't they?
Indeed. I think the UK does a good job in terms of research opportunities.
Mm-hmm.
There's a body called the NIHR, National Institute for Health Research, and together with the EME, the emerging, they have different calls essentially for different funding streams, and they funded our study on deep brain stimulation for Tourette, for example.
Fantastic, yeah.
And we also had funding from research bodies in the UK, the MRC, the Medical Research Council, for our OCD trial.
Yes.
So I think there are lots of opportunities for funding. The competition is very stiff, but so it should be. I think we should use those research. We should put our research money into projects that are going to make a difference.
A real clinical
for
difference, yeah, sure. That's fantastic. Well, thank you very much for our conversation, our chat.
It's been an absolute pleasure.